I'm very pleased today to introduce Dr. Ann Parker, who is joining us from Johns Hopkins University to share her experience treating patients with post-COVID-19 condition. Dr. Parker is a graduate of the University of Maryland School of Medicine, who then went on to receive her PhD from Johns Hopkins Bloomberg School of Public Health. Her research is focused on describing and improving long-term outcomes for survivors of critical illness, and her recent work specifically is focused on the post-acute sequelae of SARS-CoV-2 infection. She currently holds joint appointments in both the departments of medicine and PM&R at Johns Hopkins University, where she has served as both the co-founder and co-director of their post-acute COVID-19 program. She also currently serves as a member of the WHO Working Group on Care Models for Post-COVID-19 Condition. Our division had a sneak preview of Dr. Parker's work last night at our annual regional ATS chapter meeting, which was attended virtually by pulmonologists and intensivists from many different practice settings throughout the DMV area. And her presentation really resonated with all of our experiences caring for these patients over the past 2+ years. And I know you all will enjoy her lecture today as much as we did last night. With that, I'll turn it over to Dr. Parker. Thank you.
Thanks so much, Dr. Flory. It was a really kind introduction, and I really enjoyed the discussion following the talk last night. So I look forward to all of your questions. So my only disclosures include some consulting for ADAR Health, a small medical equipment development company. I'm not going to be talking about any of their devices here today. So I'll start by summarizing what we know about post-intensive care syndrome, or PICS. And specifically because when we launched our program in the spring of 2020, we of course didn't have any idea in terms of what to expect specifically regarding what is colloquially termed long COVID. And so, the term didn't even exist at that point in time. And then I'll talk a little bit more about the impact of the COVID-19 pandemic on survivorship from acute respiratory failure. And then I'll define what I like to use, the term that I like to use when referencing recovery from COVID-19 illness, which is post-COVID-19 condition. And we'll talk a little bit more about that in detail and some of the evidence that we do have at this point in time to understand what recovery from COVID-19 can look like. I'll give some more specific details on our program at Johns Hopkins for post-COVID care, and specifically touch on some of the neuropsychological outcomes that we've evaluated thus far, and then finish with some considerations directly for pulmonary management of these patients. So prior to COVID-19, based on decades of research, we know that survivors of critical illness can experience impairments in mental health, cognition, and physical function. And collectively, these are termed post-intensive care syndrome, or PICS. Importantly, PICS is a term that does not describe a diagnosable syndrome, but really was designed to raise awareness around the challenges in recovery that survivors of critical illness can experience. We know that these impairments can persist for months to years after discharge from the hospital and are associated with worse quality of life. Similarly, patients who are hospitalized and perhaps not in the intensive care unit can also have a transient period of vulnerability, and they experience impairments in similar domains. A fifth of these patients will be readmitted within 30 days. And interestingly, the reason for readmission is often different from the reason for index hospitalization. So suggesting that there's something particularly about the hospitalization itself that can potentially impact outcomes for these patients. So again, I'd like to dive in specifically to each of these domains, starting with physical function, and then we'll talk briefly about mental health and cognition as well, to summarize and emphasize what we know about ARDS and critical illness survivorship prior to the COVID-19 pandemic, because I think it really provides important context and emphasizes that we don't have to start from scratch in thinking about how we can address the immediate needs of this really rapidly rising patient population. So first, I'll start with Dr. Harridge's landmark work published in the early 2000s on one-year outcomes for survivors of ARDS. And I know most of you are familiar with this work, so this will be a bit of a summary and reminder. But what we know from Dr. Harridge's work is that over the course of an ICU stay, patients lose nearly 20% of their body weight. In the 12 months after discharge, they will gain this weight back, but there generally is a loss of lean muscle that is then replaced with fat. And so there's a change in body composition, and this has important functional implications. So in a year after discharge from the ICU, these ARDS survivors in this particular cohort were performing only at 66% of predicted on a 6-minute walk test as a measure of physical function. And again, when we think about very tangible implications, we see that only half of these patients who were generally young, had few comorbidities, were healthy and working and providing for their families prior to illness, only half of them had returned to work at a year after discharge from the ICU. From a pulmonary function testing standpoint, the most common abnormality was a decrease in the DLCO. We can see here on the bottom row of this table that these changes were mild to moderate and tended to improve with time without any dedicated treatment from an ARDS standpoint after discharge. So that's to summarize a little bit of the physical impairments that patients can experience after ARDS. So let's talk about what we know and kind of summarize from a mental health standpoint. In terms of depression, about a third of patients will have substantial depression symptoms after ICU. And these symptoms generally won't improve over that first year after discharge. Risk factors can include pre-existing psychiatric comorbidities before ICU admission, and importantly, having psychiatric symptoms at the time of discharge from the ICU or hospital. And you'll see this theme kind of carry through each of the mental health domains that we discuss. And I think also provides perhaps an important target when we're identifying patients at risk for sustained symptoms over time. The story for anxiety is much the same. So about a third of patients having substantial anxiety symptoms at a year after discharge without substantial change over time. Again, having psychiatric symptoms in the ICU or the hospital are a known risk factor. And then memories of delusional experiences that occurred in the hospital and recalling those after discharge. And then having comorbid depression and PTSD symptoms after hospital discharge as well. Consistently not associated with subsequent anxiety symptoms are things like severity of illness, ICU and hospital length of stay, and reason for admission. And so this is really important. And again, a theme you're going to see carrying through in terms of ICU survivorship, where some of the typical markers of severity of illness and mortality are perhaps not consistently associated with some of the things that are really challenging our patients and their recovery. So if we're relying on these factors, we are potentially really missing the boat in identifying at-risk patients. From a post-traumatic stress disorder or PTSD standpoint, we see that about a quarter of patients have substantial symptoms over that first year. And this is really striking because this proportion is on par with what we see for survivors of other traumatic events. So if we look at the literature for even wartime combat or being close to the sites of the World Trade Center attacks, we see a similar proportion. And so the ICU experience can be a very traumatic event for our patients. These symptoms can persist for years. And some risk factors appear to be sedation, especially with continuous infusions of benzodiazepines. And also, again, having traumatic or delusional memories of the ICU experience. And again, I'm sure all of you have heard patients describe some of these things, but some of the things that I hear are patients picturing blood pouring down the walls, dead animals in or around their room, patients recalling being assaulted, thinking that they were being attacked by the medical team or that providers or staff were kind of plotting against them. So really frightening memories that can be very vivid to patients. So we've talked about physical function, we've talked about mental health, and let's summarize what we know about cognitive impairment after critical illness, again, predating COVID-19. So this is a study of over 800 patients with respiratory failure or shock. 3/4 were delirious at some point during their hospital stay. And 1/3 and 1/4 had cognitive scores at 1-year follow-up consistent with moderate traumatic brain injury and mild Alzheimer's disease, respectively. And so these numbers are quite striking. This affected both older and younger patients. So not only patients who were perhaps older and developing cognitive impairment from, say, an Alzheimer's standpoint already, but also affecting younger patients. Importantly, the duration of delirium in the ICU appears to be associated with subsequent cognitive impairment. And this is really important. And I'll touch on this a bit more in the context of the COVID-19 pandemic. We hear a lot about fatigue following COVID-19 illness, and certainly something that we see quite a bit in our program. And again, I think important to contextualize this and understand which patients and what fatigue prevalence might have been for survivors of critical illness prior to the COVID-19 pandemic. So this is some work done by our group looking at over 700 ARDS survivors from 38 US hospitals. The facet F was used to assess fatigue symptoms, and this had been validated in an ICU population. Clinically important fatigue occurred in 70% and 66% of patients at 6 and 12 months after discharge from the ICU. So this is quite common. Being male and employed prior to illness were associated with less fatigue, while having worse physical function and greater anxiety and depression symptoms were associated with more fatigue at both 6 and 12 months. And again, I mentioned this theme where severity of illness, ARDS severity, and ICU length of stay are not associated with fatigue symptoms. And so we're really seeing this theme carry through the mental health symptoms and fatigue symptoms that we're seeing for our patients as part of their recovery. So let's touch on how we sort of anticipated when we were conceptualizing our program, how the COVID-19 pandemic and COVID-19 could further complicate recovery from critical illness. This figure is taken from a review that we wrote for Lancet Respiratory Medicine, highlighting and summarizing a potential approach and framework to use when addressing COVID-19 survivorship. And so what this emphasizes is sort of each of the domains that fall under the post-intensive care syndrome umbrella and how COVID-19 and the pandemic could further complicate recovery. So if we think about physical impairments, I think we all know as pulmonologists and intensivists that our COVID-19 survivors are quite sick on arrival to the ICU. They often require proning, paralysis, prolonged mechanical ventilation, and they can be at higher risk for myopathy. All of these things can be associated with a longer duration of bed rest, which is associated with subsequent ICU-acquired weakness and can perhaps further impact physical function. From a mental health standpoint, one of the things that Dr. Fleury and I were talking about just before the talk this afternoon, and we had a discussion about yesterday evening, is the impact of visitor restrictions on our patients from both a mental health and cognitive perspective. And so that's one important aspect of the pandemic that can further shape recovery. Similarly, patients experience social isolation in the ICU and also in the outpatient setting on the wards as part of their inpatient rehabilitation stays. We know that there's a ton of coverage, media coverage of the pandemic that has waned over time, but we certainly saw it earlier in the pandemic, and our patients who are constantly reminded of that trauma, reminded of loss of loved ones, they have a constant fear of being reinfected. They had fear of infecting others. And so there are a lot of reasons to think that perhaps the pandemic and that experience could further shape recovery from a mental health perspective. And we've touched on some of the aspects of the pandemic and COVID-19 that can complicate cognitive recovery. I'll add to that our patients, at least in my experience in the ICU, in the context of COVID-19, ARDS, we're put on very high levels of sedation for a prolonged period of time. And so that perhaps could be associated with a longer duration of delirium. And then again, we know from prior research that the duration of delirium is associated with subsequent cognitive impairment. And finally, in addition to visitor restrictions, we know in a lot of settings, patients had limited access to essential rehabilitation services across the continuum of care. And so if patients were not receiving early rehabilitation in the ICU or rehabilitation on the wards, that can further very much impact recovery across all of these domains. Now I'd like to talk a little bit about what we know about post-COVID-19 condition. So I'm deliberately using this term of post-COVID-19 condition because it is the term that has been developed by the World Health Organization as part of a working case definition. So the way this was developed is through a 2-round modified Delphi process. They were careful to include important stakeholders. So these were patients, patient researchers, non-patient researchers, external experts, so it's clinicians as well, WHO staff, and others. You can see here in the map, highlighted in green, the countries that participated. Of course, we would like to see this entire map be green so that we have a very representative sample. Round 1 included 265 participants, and round 2, 195 participants. And ultimately, this yielded the following case definition. So post-COVID-19 condition occurs in individuals with a history of SARS-CoV-2 infection, usually 3 months from the onset of COVID-19. So this differs a little bit from the CDC definition, which allows for an earlier onset of symptoms. These symptoms last for at least 2 months and are not obviously explained by an alternative diagnosis. You can see the common symptoms listed here. And importantly, and this was something that I think a lot of people felt strongly about as part of the case definition, is that these symptoms impact everyday functioning. Now, these symptoms can be a continuation of those experienced during the acute phase of illness, or they can be new in onset. And there can be a relapsing and remitting course, which we commonly see in our patients. What we know in terms of COVID-19 survivorship and prospective longitudinal studies really are coming first from our colleagues in Europe and China who are ahead of us in the timeline of the pandemic. So this is a study from Italy of over 700 patients. Only 10% of these were in the ICU, so largely a study of non-critically ill patients. They were evaluated at a median of 105 days after discharge. Half of these patients had at least one symptom, most commonly fatigue or shortness of breath. From a pulmonary standpoint, about a third of patients reported breathlessness, and the most common abnormality was a decrease in the DLCO, which is consistent with what we saw from Dr. Harridge's work from the early 2000s and following ARDS survivors over a year after discharge. There was a high prevalence of PTSD symptoms in this cohort, a third of patients reporting substantial symptoms of PTSD. In terms of physical function, 16% were no longer independent at this time. Fatigue, again, was common, occurring in 44% of patients. They found a low rate of cognitive impairment when using the MoCA to evaluate cognition, and I'll present some data later, perhaps that points to maybe the MoCA isn't the most sensitive instrument in this patient population. They found only 2 asymptomatic subsegmental pulmonary embolisms. These were found by investigating an elevated D-dimer in more detail. And then less than 10% of individuals had any of the following symptoms: palpitations, GI symptoms, headache, cough, and persistent loss of taste and smell. And you'll see that the story is similar that's emerging from China. So this is a study at 6 months after discharge of about 1,700 patients. Very few required invasive mechanical ventilation or ECMO. So again, largely a study of non-ICU hospitalized patients. 3/4 of patients had symptoms at 6 months. Again, most commonly fatigue and muscle weakness. From a pulmonary standpoint, about 1/4 had breathlessness. Again, the most common abnormality in PFTs was a decrease in the DLCO. And about 1/4 of patients had anxiety and depression symptoms on self-report. Only 5% had more than slight symptoms of anxiety and depression. In terms of physical function, patients were performing at about 88% of predicted on the 6-minute walk. And they evaluated about 400 patients with lower extremity ultrasound, and they did not identify any new DVT at 6-month follow-up. A greater proportion of patients in this cohort who required at least high-flow nasal cannula or more respiratory support compared with those who required nasal cannula or less support reported breathlessness, decreased mobility, and anxiety and depression symptoms. And so perhaps some association, at least in this cohort, between severity of initial illness and subsequent impairment. So the same cohort was followed out to a year. And so they were able to capture 1,200 of that initial 1,700 patients. At this point in time, so at 12-month follow-up, 50% of patients were reporting at least one symptom, compared with 3/4 at 6 months. Again, most commonly fatigue, although the proportion is decreased. There was a slight increase from 26% to 30% of patients reporting breathlessness at 6 to 12 months. DLCO was, again, the most common PFT abnormality, but what I've highlighted here is that there was a decrease in the proportion of patients meeting criteria for restriction on pulmonary function tests from 6 months to 12 months. There was no substantial change in the proportion of patients reporting anxiety and depression symptoms, and again, really no change in the 6-minute walk test from 6 to 12 months. Compared with matched controls, a greater proportion of COVID-19 survivors had breathlessness, decreased mobility, pain, anxiety, or depression. So at 6 months, this group compared patients requiring higher levels of respiratory support to lower levels. And at 12 months, they were able to match to controls who did not have COVID-19. We're starting to see some data emerge looking carefully at control groups, which is just a really important part of evaluating COVID-19 recovery. And so this is a letter from Pedal Network sites looking at, that's my next slide. So looking at 120 COVID-19 versus 199 non-COVID-19 mechanical ventilated patients. And they used pre-pandemic historical controls as the non-COVID-19 patients. In both groups, phone surveys were administered at 6 months. These included the EQ-5D for quality of life, the Hospital Anxiety and Depression Scale for depression and anxiety, the Impact of Events Scale 6-item version for PTSD symptoms, and the MOCA for cognitive evaluation. Importantly, all of these surveys are a part of a validated core outcome measurement set for research in acute respiratory failure survivorship. They also included a measure of disability. And the duration of mechanical ventilation was longer in COVID versus non-COVID patients. There was no difference in mortality at 180 days or new disability. And anxiety, depression, and cognitive scores were similar between the COVID-19 and non-COVID-19 groups. So the take-home message is that incidence of new disability, severity of disability, quality of life, neuropsychological function were really similar for COVID-19 and non-COVID-19 acute respiratory failure survivors. I'd like to just briefly touch on what we know thus far about any potential association between vaccination and subsequent post-COVID condition symptoms. So this is a study from the UK published in September of 2021, nested case control study. They had over 6,000 patients who had at least one dose of a vaccine, and then over 2,000 with a second dose. So this is really looking at 2-dose vaccine prior to boosters. And then they had matched controls who tested negative in the same time frame as the COVID-19 positive individuals. So risk factors for infection after a first dose of vaccine included frailty, specifically in older adults, living in what were termed deprived areas, and obesity. Vaccination was associated with a reduced odds of hospitalization, and that was true after both the first and second doses. A reduced odds of having more than 5 symptoms in the first week of illness, again, true after both the first and second doses, and having a longer duration of symptoms beyond 28 days, specifically after the second dose. Vaccination was also associated with a lower frequency of almost all symptoms, and it was associated with having asymptomatic illness, again, especially in older individuals. And these data are supported by a preprint that recently came out from our colleagues in Israel. And so we're starting to see in these larger studies some support that vaccination is perhaps associated with fewer and a shorter duration of symptoms, especially in the acute and perhaps post-COVID setting. And so when I'm counseling patients, we often get the question in our program about this, any potential association between vaccination and post-COVID condition. I remind everyone that vaccines are effective in preventing infection and preventing severe infection. So that's the first take home. If you don't get COVID-19, you're not going to get post-COVID-19 condition. And then I share this information as well in terms of once looking at individuals who have been vaccinated and are infected, the subsequent decrease in the number and duration of symptoms. We do not see pediatric patients in our program, and I will not claim to be an expert in pediatric post-COVID condition, but I will highlight the efforts of some of my colleagues at Hopkins and the Kennedy Krieger Institute. So pictured in the top half of this slide is Dr. Christy Sadramelli, who is an assistant professor in the Department of Pediatrics at Johns Hopkins and a pulmonary doc as well. And she is working closely with us and following especially the patients who are developing interstitial lung disease or have interstitial lung disease and have had COVID. So it's been really a pleasure to work with her, and especially in coordinating care for those patients who sort of bridge the pediatric and adult settings, our older teens or young adults. And in the bottom half of the slide, you can see Dr. Amanda Morrow, who's an assistant professor in the Department of Pediatric Physical Medicine and Rehabilitation, and Dr. Laura Malone in neurology for pediatrics. And they are really leading the efforts in the Kennedy Krieger Institute and have directed and founded their pediatric post-COVID rehabilitation clinic. This is a review article summarizing a little bit about what we know in post-COVID condition in children. And so this highlighted 14 studies that included over 19,000 children and adolescents. They tried to tease out MIS-C from more what is termed post-COVID condition or long COVID. One of the biggest take homes is that there was a lot of heterogeneity in the studies, and this is true in the adult setting as well. And this included variability in inclusion criteria, design, outcomes, timing of assessments. There is always a concern, and I think, again, true for our adult studies as well, for selection bias and response rates. And so I'm always careful, especially when interpreting studies that are based on social media or web-delivered survey data. I think they can provide important information, but always within the context of understanding how selection bias might impact those results. You can see there's a very wide prevalence range of these symptoms in the pediatric population. 5 out of 14 studies included a control group. Of these, 3 reported persistent symptoms being more prevalent in children who had SARS-CoV-2 infection. And so I think the take-home message from this review is really understanding the importance of control groups to determine the effects of a SARS-CoV-2 infection versus the pandemic, specific factors like school closures, social isolation, loss of a primary caretaker, and how that might impact recovery from COVID-19 and experience in the setting of the pandemic. So I'd like to share a little bit about our experiences and how we've approached post-COVID care at Johns Hopkins. So we started our program and saw our first patient on April 7th, 2020. And you can see pictured here myself. I've led the efforts on the pulmonary and critical care medicine side, and Dr. Alba Azola, who is leading efforts on the physical medicine and rehabilitation side. So we are a multidisciplinary program as a partnership between pulmonary critical care and physical medicine and rehabilitation. We started almost entirely as a telemedicine program because of infection and prevention control measures in the spring of 2020. And then in December of 2020, we began seeing patients in person as well. So we now have a hybrid model where we can see patients via telemedicine or in person. We have 2 components. So we see patients who required higher levels of respiratory support as part of our ICU clinic. And we have our base component where we see patients who have ongoing pulmonary and or rehabilitation needs at the time of discharge or simply ongoing needs for those who were never hospitalized. One of the hallmarks of our meetings of our program is weekly multidisciplinary meetings where we are able to discuss each of the patients that we've seen over the prior week. I think we are all humble and recognizing the constantly changing evidence base and landscape. And so it's really great to be able to pull on the expertise of our multidisciplinary team when we're thinking about how we can best approach a patient's care. So again, when we started our program in the spring of 2020, of course, we knew nothing about what is termed long COVID or post-COVID condition. And so our framework did very much rely on an understanding of post-intensive care syndrome and anticipating the needs of at least the subset of patients we saw at that point in time filling our intensive care units, and understanding that there were gaps in care that we wanted to fill for those patients as they moved through the continuum of their illness and recovery. And so specifically, we know that early rehabilitation in the intensive care unit is associated with improved outcomes for our patients. Our patients also often receive excellent rehabilitation services in the acute setting and inpatient rehab, but there is a gap in filling and supporting these patients in the ambulatory and post-discharge setting. So when conceptualizing this, one of the approaches that we took really focuses on what we see in this figure here, which was taken from a protocol paper for a study evaluating how unmet needs after discharge are associated with subsequent readmissions and mortality. And this is specifically in acute respiratory failure survivors. So you can see each major domain or discipline highlighted here, and this is what we tried to address as we were conceptualizing our clinic. So we partnered with pharmacists for our patients who are in need of detailed medication reconciliation, recognizing that many patients have medications that are inadvertently continued from the ICU setting into the outpatient setting, medications that were stopped upon admission that need to be restarted, et cetera. We partnered with Johns Hopkins Home Care for the provision of inpatient and home rehabilitation services and medical equipment. The Hopkins Home Care program, I think like most places, also had a remote patient monitoring program throughout the pandemic that was really helpful, especially for those patients who were discharged either from the ICU or acute care setting on supplemental oxygen, helping them to titrate and even at times wean off of that oxygen before they're seen in follow-up care. Again, we have subspecialty medical care that really includes pulmonary. We've partnered with our colleagues in cardiology for targeted referrals to individuals who really have an interest in this patient population, both from a clinical care and research perspective. And it's been really great to partner specifically with Dr. Karthik Suresh, who's one of our interstitial lung disease experts and is seeing patients under our PACT umbrella who have more advanced fibrotic lung disease. Of course, as I mentioned, physical medicine and rehabilitation is half of our program. And so our patients have a visit with physiatry, and then we are also tied in with physical therapy, occupational therapy, and speech language pathology. And we're fortunate to also under the PM&R umbrella have access to rehabilitation psychology, both for mental health symptoms and cognitive impairment. So we've seen over 700 patients in our program so far. Median age is about 55 years. That has shifted slightly over time. A little over half of our patients are female. A third identifies Black or African American, and about 15% is Hispanic or Latino. This latter proportion has decreased somewhat over time, and I think there are multiple possible explanations. We can think about shifting demographics in the setting of the pandemic, vaccination, and I think always trying to keep an eye toward access and equity. And so pictured here is Dr. Panagis Galiot-Satos, who's one of the pulmonologists who sees patients in our program. And he's pictured here with one of our PACT patients. And he really is leading efforts to kind of understand that equity and access standpoint. So important to kind of think about how we can best deliver high value care for our patients, and important to be humble and recognize that we do not have a very strong evidence base in terms of identifying which interventions are most beneficial to our patients recovering from COVID-19 or even from critical illness in general. So many programs like ours have been developed across the country over the past 2 years. There are ICU follow-up programs that have existed in the United States and especially in Europe prior to the COVID-19 pandemic. And this is really a young field and one that I think requires and is rightly receiving at this point in time a lot of attention in terms of understanding what is in fact helpful for our patients. So this is a letter from working with the PEDAL network. This included a survey that was completed by 47 of the 51 PEDAL sites. This survey asked about what kind of COVID information was being provided at discharge and asked some more detailed information about post-COVID programs at each of these sites. So 80% reported providing COVID-specific information at discharge, but only 26% provided any information on post-COVID conditions. So I think there's one potential area and a gap in care that we could address. 70% reported having a post-COVID clinic. Importantly, there was a lot of heterogeneity in the approach, the assessments, the timing of follow-up, eligibility, you name it. Hospitals without versus with post-COVID condition clinics were more likely to be smaller for-profit sites, more likely to have a zip code with a median annual income of less than $40,000, and a higher proportion of patients insured by Medicaid. So I think this highlights some important areas for further research. So I mentioned really identifying which interventions work for which patients at what point in time, et cetera, and also making sure that as we identify those interventions, that they're accessible to patients who need them, because right now these efforts are really focused in large academic medical centers. So I'd like to share a little bit of the data that we've recently published on neuropsychiatric outcomes for our patient cohort. So as part of their initial clinic intake, patients undergo a clinical cognitive testing battery that's administered over the phone ahead of their first appointment. This battery is derived from the multi-ethnic study of atherosclerosis, or MESA, and the NACC uniform data set. Scores are then compared to age-adjusted published normative data, and we look at whether rates of impairment are in excess of what we would expect for this battery. And we classify impairment as mild or moderate or severe as pictured here in this box. And I'll emphasize that this work has been made possible through a collaboration with the Johns Hopkins Memory and Alzheimer's Treatment Center, led by Dr. Esther O and Dr. Kostas Leketsos, and also Dr. Tracy Vandersdaal, who's a neuropsychologist in the Department of Psychiatry. And this has been just a fantastic collaboration that has been in existence since the summer of 2020 and has really, I think from my point of view, emphasized how we can deliver high quality clinical care while also partnering with our colleagues who are really interested from a research perspective and advanced knowledge in the field. As part of this battery, we do administer standardized measures of depression, anxiety, PTSD, and the QDRS for functional decline. I'm sharing the early data that we have from our English-speaking patients, and we do administer the battery in Spanish as well, and hopefully those data will be forthcoming. You see here 82 patients split between patients who required ICU level care for COVID-19 and those who did not. We've now administered probably close to 400 initial surveys, and we are starting to make a dent into the follow-up surveys. So we have some longitudinal data on this patient population. You can see that patients who required ICU level care tended to be a little older and have a slightly fewer years of mean education. So on this graph, lower scores reflect poorer performance on each of these cognitive domains. And so you can see patients treated in the ICU, as well as those who did not require ICU level care, tended to perform below what would be expected on most tests, especially those of fluency, processing speed, new learning, and memory. Pretty much across the board, patients who required ICU level care tended to have even lower scores. Overall, about 2/3 of our patients had at least one score in the mild to moderate or severe range of impairment. And when we look specifically at measures of depression, anxiety, PTSD, and functional decline, we see that nearly 80% reported mild elevations on at least one measure, and 35% reported moderate elevations on at least one measure. The QDRS is very heavily weighted to changes in function that are due to mood and thinking. And importantly, scores on measures of depression, anxiety, and functional decline did not differ necessarily whether patients were in the ICU or not. We did see, of course, a big difference in terms of PTSD symptoms. Also importantly, depression, anxiety were not consistently related to cognitive composite scores. So this disconnect between mental health symptoms and actual performance on a cognitive battery. We actually recently submitted an abstract on this aspect of our data, which I think is really important and thought-provoking, and I think important to consider and fits with what we know about self-performance measures in general. And so in terms of understanding the association between subjective cognitive reports and objective cognitive performance on a battery, we see in terms of subjective cognitive reports that for patients in the ICU, there's an association with younger age. And again, for subjective cognitive reports for non-ICU patients, we see an association with depression. However, we are also seeing that subjective cognitive reports, as well as anxiety and fatigue symptoms, are not associated with objective cognitive performance. And I don't think this is terribly surprising. We know that this is often a limitation on self-reported measures. And this is a study published actually just prior to the pandemic from the OASIS research group at Hopkins, looking specifically at this issue in terms of ICU survivorship. So 59 acute respiratory survivors, again, pre-COVID, so these are patients who did not have COVID and prior to the pandemic, completed standardized outcome measures and qualitative interviews. The standardized outcome measures, again, were in line with the core outcome measurement set for acute respiratory failure research. So for physical function, this included the SF-36 physical component summary and the EQ-5D mobility score. For mental health, again, the HADS and the IESR, and then cognition, you can see listed here. So worse scores. So what we saw were worse scores on standardized outcome measures for survivors who reported versus did not report physical and mental health impairments in qualitative interviews. However, and in line with what I just presented from our cohort, standardized cognitive testing scores did not differ between patients reporting versus not reporting cognitive impairments. So in summary, in terms of what we're seeing so far regarding neuropsychiatric outcomes, at about 4 months after acute illness, 2/3 of patients are having some evidence of cognitive dysfunction with multiple domains impacted. Cognitive dysfunctions occurring in both ICU and non-ICU COVID-19 survivors, with patients who are requiring care in the ICU seeming to have more severe and broad impairments overall. More than 1/3 have clinically meaningful mental health symptoms and impairments in function. And we're seeing that subjective cognitive impairment may not be associated with objective cognitive performance. We have very little COVID-specific research thus far guiding how we address cognitive impairment in this patient population. And so we rely on an evidence base from other acute and chronic conditions. And this is largely rehabilitation-based. So for our patients who require further evaluation, they're referred to neuropsychology. They're also referred to speech language pathology, sometimes occupational therapy, rehabilitation psychology for further management and helping them to cope and identifying some aids that they can use as they're navigating this part of their recovery. And then again to psychology and psychiatry for mental health impairments as needed. And admittedly, these services, I think across the country, we're seeing that the need is far outpacing what is available in terms of support. So I'd like to finish just briefly and touching on some considerations for pulmonary management in this patient population. So I think two things that often come up that we discuss are if and when to use steroids in the post-COVID setting. And the other medication that I'll touch on are antifibrotics. So in thinking about corticosteroid treatment, this is a study at about 4 weeks after discharge, looking at about 800 patients, 39% who were symptomatic, meaning not back to baseline yet after their COVID-19 illness. About 5% of these patients, so 35 patients altogether, had some evidence of interstitial lung disease paired with functional impairment. 30 of these 35 received prednisolone, tapered over a 3-week period. And what they tended to see was improvement in FVC and radiographic improvement as well, and they did not report any major adverse events. And so this is a representative CT from top to bottom of a patient who received steroids as part of this non-controlled study. And so what I'll mention is that I think, one of the abstracts that were presented as part of the conference yesterday evening was highlighting a patient who developed mucormycosis in the setting of steroids for COVID-19. And, while there were no adverse effects identified in this study, I think we can all recognize the potential impact of a prolonged steroid course for our patient population, whether it be infection or development of prediabetes or diabetes, elevated blood pressure, et cetera. And so ideally, we would have some rigorous randomized controlled trials evaluating steroids specifically in these instances and identifying which patients might benefit in the ideal steroid course. And so we tend to approach this on a case-by-case basis and with caution, again, recognizing based on the literature that we have from ARDS survivorship in general, and also emerging in the post-COVID setting, I believe, where pulmonary function tests for most individuals tend to reflect mild to moderate impairment that improves over time without intervention. And so I think really bringing caution to initiating a prolonged steroid course. We do it on selected cases, and there are certainly instances where it's warranted, but just thinking carefully about that. The other medication that is often considered and discussed, especially for, of course, our patients who have fibrotic changes, post-ARDS and abnormal PFTs, is antifibrotic medication. And so we're excited to join a multi-site study of oral nintedanib for post-ARDS fibrosis in this patient population. This is being led by Mount Sinai in conjunction with BI Pharmaceuticals. The site PI at Hopkins is going to be Dr. Karthik Suresh, who is our interstitial lung disease expert in the PACT program. So this is an RCT, double-blinded. The control is placebo. You can see the eligibility criteria listed here. And the primary outcome is a change in FVC at 180 days. Importantly, there are secondary outcomes looking at patient-reported measures and measures of physical function, including the 6-minute walk test. So hopefully more to come. I think this is a question that's been in a lot of folks' minds in the post-ARDS setting in general, and certainly in the post-COVID setting. And I think one benefit of having some of these post-COVID condition programs is an opportunity to recruit and, again, to conduct research alongside clinical care to identify high-value interventions. So I'd like to come full circle and just to highlight this particular case. So this is representative of some of the patients that we see who have required prolonged mechanical ventilation in the ICU. So this is a patient who required 3 months of care in the intensive care unit, was on mechanical ventilation, prone and paralyzed, for quite an extended period of time, required a tracheostomy and a PEG tube. After this prolonged ICU course, spent 2 weeks in acute inpatient rehabilitation. And you can see here a representative cut of this patient CT on the top left, during the acute phase of illness. And on the bottom right, a CT from 7 months later. PFTs are reported here. And this patient was off of supplemental oxygen at the time of this follow-up CT. And so what I think this highlights, and also the important thing to know about this patient, is this patient is back to work part-time. And the most frequent or most common reason for this patient to interact with healthcare at this point is ongoing physical rehabilitation, as well as interacting with mental health providers. And so again, this highlights that our patients have really amazing pulmonary reserve. And while this is an important consideration, of course, in their recovery from acute respiratory failure, it's also really important to think about the neuromuscular and neuropsychological complications that can often, as much, if not more, impact their recovery. So in summary, survivors of critical illness, including those with COVID-19, commonly experience impairments in physical, cognitive, and mental health. Post-COVID condition is a constellation of symptoms that occur at about 3 months after initial diagnosis and can persist for at least months. And in terms of research priorities, we know that the NIH has launched the Recover Initiative to really conduct a rigorous prospective cohort study of exactly some of these gaps in knowledge to understand incidence, prevalence, natural history, and risk factors. We really have a lot of work to do to identify potential therapeutic interventions. And I think this can be done alongside clinical care. And I do think there is a role for multidisciplinary programs, but we have to be careful and humble in understanding that we don't know which parts of these programs might be most beneficial for our patients. How do we identify which patients are most likely to benefit, the timing, and how to best deliver this care? So all really important considerations that can advance the field of post-COVID recovery, but I think also critical illness recovery and recovery from other chronic conditions as well. It's taken an army to initiate and sustain our program. I couldn't even begin to thank everyone here. And if you're interested in more information, we do have a website, and this is our PACT email address as well.